And that brings us right to our next session, leveraging all the players, empowering healthcare teams to implement evidence based care, and enabling patients to participate in controlling their blood pressure. It's indisputable that team based care improves blood pressure control. Team based care has been a core strategy that has qualified practices and systems for recognition as Million Hearts hypertension control champions. So, how do we fully activate the care team and better engage patients so that hypertension control becomes a coordinated, team based effort rather than a series of disconnected or fragmented interactions? We're joined now by a group of insightful leaders who will help us explore this from multiple perspectives. First, Dr. Crystalline Weaver, who's the CEO of the National Alliance of State Pharmacy Associations, and she'll discuss how we can better leverage pharmacists and the broader care team to expand access and improve hypertension control. Next, Dr. Erica Spatz, Associate Professor of Cardiovascular Medicine at the Yale School of Medicine, will share health system strategies that integrate multidisciplinary approaches and drive scalable team-based care models. And then Dr. Yvonne Commodore-Mensah, Professor and Associate Dean for Research at the Johns Hopkins School of Nursing and faculty member in the Bloomberg School of Public Health, will focus on how we engage patients and advance population health strategies to reduce disparities in hypertension control. As with the previous session, I encourage you to submit your questions throughout this one using the Q&A button. And now let's move to Dr. Weaver.
Well, thank you so much for the invitation to be here today. I've already learned a lot just listening to the last panel, so I really appreciate being part of the event today. Just quick introduction, I'm Crystal Weaver. I'm a pharmacist. I'm also a lawyer. Don't throw any tomatoes at me. Hypertension is so close to my heart. I became a pharmacist in large part because I've come from a family of pharmacists, but decided to go down this road after watching my very dear grandma suffer with extreme hypertension her whole life. And she hated taking her medicines because they made her tired and she was not compliant. And I wanted to make a difference for other people in that realm. Got into it and realized I'm more suited for the policy side. And so this is the perfect place for me to bring my passion. So really appreciate the invitation, John. So I'm going to talk about some opportunities with pharmacists today. So the real opportunity that we have with pharmacy is that, as you all know, most Americans with hypertension are uncontrolled. And that's not because there's not available treatments that work. We have lots of medications that work, but the bottleneck is really having enough access, follow-up, and titrating those medicines to work optimally for our patients. But we have 9 in 10 Americans who live within 5 miles of a community pharmacy. So we have a lot of infrastructure available. And that's a workforce sitting right in plain sight with more touch points than any other setting can offer. Patients walk into their pharmacy multiple times per month, whether it's to pick up a medication refill or to pick up something else that they need from the convenience end of the pharmacy. So there's a lot of opportunity there to get pharmacists in front of patients to manage hypertension. And when we let pharmacists manage hypertension, the model really works. I have some stats up from one study, but there are many, many studies on this topic showing that pharmacists can make an impact. This study from JAMA, a pharmacist-led team, nearly doubled the rate of blood pressure control from 30% up to 57%. And there's many studies that echo support for pharmacists' involvement in managing hypertension across practice settings and in different delivery models. So this really isn't an experiment anymore. In pharmacy, we love to do demonstration projects showing how pharmacists can support patient care, but we're really past the demonstration phase and we need to move on to implementation and scale. So pharmacists can function in many different practice settings and can support the healthcare team in each of those settings with hypertension management. So in one setting, pharmacists can be embedded in primary care, working under collaborative practice agreements or other types of arrangements to manage titration and adherence between visits with their primary care provider. And that's the highest touch model and shows the largest reductions in the literature. I'll just share in this is real life in Washington State, where they've had collaborative practice authority for pharmacists to manage medications directly for probably close to 50 years now. I was going to say 40, but I think it was 10 years ago that we hit the milestone for that. And so it's really embedded into their culture that pharmacists participate in these collaborative practice agreements and are part of the care team. And our pharmacy association there estimates that about 30% of the workforce is embedded in these types of clinics and ambulatory care settings. So this is a real opportunity to spread to other areas of the country too. And then, of course, community pharmacist programs can reach patients where they actually are. And there's a lot of opportunities to provide screening services, MTM, and in a growing number of states, even independent prescriptive authority. And we can unlock that setting if we reduce some different barriers to provide more of that higher touch care as well. And then there's also telehealth models where we can have kind of a hub and spoke approach to use telehealth to enable pharmacists to bring care to rural areas or under-resourced systems that can't have their own pharmacist embedded, but the pharmacist can serve that setting from a distance. And of course, you all know hypertension is a team sport, and pharmacists also work best when they're paired with medical assistants and nurses who are doing accurate in-clinic measurement and onboarding, with community health workers and pharmacy technicians who can address social determinants of health, transportation challenges, delivery of medications, and build trust in the patient populations that they serve. And with physicians and nurse practitioners and physician assistants who set the treatment plan and lean on the pharmacist to make those titration and follow-up services happen after the fact. And the pharmacist can serve as this connective tissue between each of these different layers of care. So the real issue is what's holding us back. We have lots of data that this works. What's keeping us from getting there? The first is a big issue that pharmacists are not recognized within Medicare Part B, as in boy, as a provider. And so we cannot bill or be paid for services that we provide in Medicare to a large extent. Scope of practice varies widely from state to state. So what's allowed in one state may not be allowed in another. And really technology. One of our speakers earlier talked about the importance of sharing data through an interoperable EHR. Most pharmacies do not have that interoperable access today. And so there's a lot of limitations there in the data exchange realm. Some opportunities for us to work together to make change. Championing provider status. That tends to be a bad word that we've stopped using because some groups take issue with it, but we do have bills available in Congress right now that would recognize pharmacists. I think there's a real opportunity with the Rural Health Transformation Program to get pharmacies linked up through EHRs. And then, of course, health systems can invest in pharmacists now. If you're able to, invest in the pharmacist who can serve on the team and help get hypertension under control. Thank you.
Beautifully done. Thank you, Dr. Weaver. We will now move on to Dr. Spatz.
Hi, everyone. I am glad to talk to you today about health system strategies that integrate approaches that were described by Dr. Weaver and seeing how they can play out in both small and big ways in your health system. So as we all know, home blood pressure monitoring is now a Class 1 recommendation for both diagnosing and controlling hypertension. And so this is exciting because we have data that shows that the blood pressures that we get at home are better than the ones that we get in the office. We know there's a lot of white coat hypertension, up to 30%. But when we try to do this for all of our patients, there's a really heavy load on clinicians. So the data may come in via MyChart messages. They may come in on a stained napkin, but they're not often delivered in a structured way. And a lot of times if patients are using MyChart or other kinds of patient portals, there's a high in-basket load. It leads to a lot of uncompensated and poorly documented work that can take place after hours. And a lot of clinicians don't have that extended care team to support them. Moreover, what we're doing with home blood pressure monitoring, even if we have wonderful home blood pressures, many of them are not visible for us to ensure high quality within our practices or to report out for quality measures. So there's poor documentation and they're not available for value-based care programs. Moreover, we have challenges with remote monitoring devices. When we don't have an established program, patients may be using non-validated blood pressure devices, of which there's lots of them on Amazon that haven't been validated through AMA. Devices can be costly, there's variable connectivity and variable insurance coverage. And I would submit to you that when this is happening, when clinicians are doing home blood pressure monitoring, despite there being codes, most of us are not billing for this work that we're doing. So the case for remote patient monitoring really, I think, needs to go up one level from the clinicians to the population health approach of a health system. And in doing so, we really can make the case that we can achieve the quadruple aim: improving quality of care, which means controlling blood pressure and improving downstream health outcomes, improving the patient experience. Patients don't need to come into the office to get their blood pressures taken again. They can be managed at home, and seeing the blood pressures at home can help them to feel more in charge of their health. They can see connections between their diet or stress levels and find self-management techniques. They may see that missing a dose of their medication results in an increased blood pressure. So it supports more patient engagement and empowerment. The clinician experience can be enhanced if we do things from a population health approach, ensuring that clinicians stay in the driving seat, setting goals with their patients, but getting help with the care that's needed to deliver ongoing home blood pressure monitoring without increasing in-basket messaging. And then those value drivers that health systems really want to see. How do we unclog our clinics and make capacity for new patients or sick patients? How do we decrease acute care visits amongst our chronic disease patients, including people with hypertension? How do we get to shorter lengths of stay, reduce readmissions, and of course, better performance on our value-based care measures? So what are some key strategies that health systems can adopt? One is to really start with aligning goals between your population health teams, your primary care, and specialty care. This is something that should not happen in silos. This really affects everyone, and the more people you can bring around the table, the better. Also, partnering with our digital health departments is really important. Establishing some standards around device acquisition and dispensing, managing incoming data, how we're going to connect to the health record if we can, and then really thinking about what are we doing with that data? Can we put up a team-based approach to managing blood pressure? I'll tell you about a program that we started at Yale that started small, because I think it could give you some ideas of what you could do now, and then something that you could do more at the health system level. So within our digital hypertension program, we decided that patients who had persistently uncontrolled blood pressure would be referred to our program. The blood pressure device could be anything. It could be Bluetooth enabled, which then has an app, which is not so great. It could be cellularly enabled, and we could sync it with our medical records so that there's no digital tech necessary, that blood pressures just seamlessly flow through. It could also be that patients are manually inputting their blood pressures in through their patient portal. We'll take it any way they come, but we want to get them an Epic. And then what we did was we engaged with our pharmacy team using telehealth visits. They monitor the incoming blood pressures. We use a collaborative drug therapeutic management contract, and they are able to prescribe medications. We have, again, any way we'll take the blood pressures. We want the blood pressures to get into the medical record, as you can see here, just in a regular review flow sheet. And then our pharmacists use a care pathways where we have low dose combination pills to start with. These were modified from health systems like Kaiser and Geisinger and are very effective protocol-based strategies. Of course, pharmacists have the flexibility to prescribe anything that's consistent with our guidelines, but these protocols have been very helpful. And then once the patient's done with the program, they graduate. We launched this in cardiology. We were able to extend it to our maternal fetal medicine program for postpartum hypertension. We never got to employee health, but we then did community screening, so more proactive outreach. We had a lot of wins and challenges, and here's where there's a lot of opportunities. On the win side, we got experience establishing care teams. We onboarded clinicians, getting some of those early adopters in, seeing what their experiences were, and then those laggards were like, oh, I want in now too, because they could see the benefit for patients. We were able to improve workflows to optimize patient experience, develop and implement pathways for hypertension control, identify best practices for referring, managing, graduating patients, and really we came out with high satisfaction amongst patients and clinicians. However, there were several challenges that limited scalability. Those included, but are not limited to, an unreliable source of blood pressure cuffs, different types of connectivity that challenges you with data collection and aggregation. We were not billing, we were unable to scale to really all of our primary care practices where we want this to live. And it was hard to track the impact and outcomes and value at the health system level. So with all of these data in 2025, we did partner with a vendor that can offer remote patient monitoring for hypertension at scale. Importantly, this model is sustainable, meaning that it operates off of reimbursement. And so it's something that our health system was very interested in. And it's something that can be measured. We can measure uptake of the intervention. We can measure how effective it is in controlling blood pressure, the outcomes on acute care utilization, and then cost. So these are the different types of strategies that I think can be available to you. And I hope that wherever you're starting, you get started. Thank you.
Thank you, Dr. Spatz. Boy, I have a bunch of questions about what you just presented. That's great. We need to move on to Dr. Commodore Mensah. Before we do that, I just want to point out that there are some great comments in the chat. So if you haven't turned chat on, I urge you to do so and take a look at what some of our fellow participants are saying. There are a lot of valuable comments from important perspectives. Now, Yvonne, take it away.
Great. Thank you so much for inviting me to be here today. I'm Yvonne Commodore Mensah, and I'm also really glad that we are modeling team-based care today, having a pharmacist, a physician, and now a nurse talking about how we can engage patients. So I'll share our experiences conducting the Linked BP and Linked Hearts programs. And so Linked BP and Linked Hearts are distinct trials. There are some similarities, but there are distinct differences that I need to point out. Let's first start with Linked BP. I really appreciate that my colleague, Dr. Guni, mentioned earlier that normal blood pressure is less than 120/80, but we know that we have patients whose blood pressure may not be normal, above 120/80, but maybe less than 140/90. And the traditional stance in some settings for some clinicians or health systems may be to wait and see, and that's not acceptable. If we want to take down hypertension, we need to do more to prevent that progression from elevated blood pressure or stage 1 hypertension to stage 2 hypertension. So Linked BP seeks to do exactly that. We have already recruited 470 participants from 20 primary care sites across the Maryland and DC area, and some of them are considered federally qualified health centers. And in terms of the intervention, it includes a community health worker, the use of home blood pressure monitoring, and a mobile health application. And Linked BP is funded by the American Heart Association. And on the right side, we have Linked Hearts. So Linked Hearts focuses on people who are diagnosed with stage 2 hypertension, but also have other chronic conditions such as diabetes or chronic kidney disease. We know that often many of our patients don't just have hypertension, they're also diagnosed with other chronic conditions that may make controlling blood pressure even more challenging. So here we've recruited 425 participants so they can be Black, white, and also Hispanic, and also recruited across primary care sites in the DC, Maryland metropolitan area. And in terms of the intervention, the components are fairly similar to Link BP, but the main difference here is the inclusion of a pharmacist, because again, you have patients diagnosed with multiple chronic conditions, and that study is funded by the NIMHD. Next slide. And so the evidence is clear. Home blood pressure monitoring is one of the effective ways to improve blood pressure control and maintain blood pressure control. Now, some may consider this a bold idea, but every patient who's diagnosed with hypertension needs access to a validated home blood pressure device to monitor their blood pressure. But again, it's not enough for them to just have access to the device. We need to find a way to share readings with a clinical team. And now there are mobile health applications, and the one we use for Linked BP and Linked Hearts provides a list of validated blood pressure devices that are Bluetooth enabled that sync with the app. And what I'm also grateful for is that this app is available in 4 languages, in English, in French, Spanish, and Mandarin Chinese. We also need to consider the fact that our population is getting more diverse. So as we think about technology and tools, we need to make sure we're reaching all patients. Next slide. But we also need to consider that it's not enough to simply give someone a blood pressure device. I think we've seen this. There are people who have Pelotons or treadmills in their basements and never use it, right? So technology is important, but it's insufficient. And so the evidence is clear that in the case of home blood pressure monitoring, patients need additional support. And the support can come in the form of community health workers. So often you hear about trials and don't get to see the faces behind the intervention. So just wanted to take this moment to highlight our amazing community health worker team. 2 of them are bilingual, again, to the heart of making sure that we're reaching all patients. Because we are also recruiting Hispanic patients, we wanted to make sure that we had bilingual community health workers as well. So they meet with a patient at baseline at the site. They teach them how to use a home blood pressure device. They tell them what to do if blood pressure is too high or too low. They also show them how to use a mobile health application and help them sync the app with their blood pressure device. So, and they also assess social needs at baseline. We've talked about the importance of understanding social determinants of health. So these community health workers have been instrumental in both Linked BP and Linked Hearts. But in Linked Hearts, we have the pharmacist, and I really loved all of Dr. Weaver's comments. So Samantha DeMarco is our pharmacist. She's never met any of our participants in person, but has over the past 2 to 3 years provided support remotely and has made a tangible difference in improving blood pressure. She's helped people get on CGMs as well and has been a key member of our Linked Hearts team. Next slide. So I don't have blood pressure outcomes for you, but what I do have is process outcomes as well. So, and Dr. Ferdinand mentioned this, that 15 minutes is not enough for most patients to really understand how to better control their blood pressure. So our community health workers are making a difference. You can see the numbers in terms of the baseline visits that are conducted. The average length of the community health worker visit, the mean is about 50 minutes. So you have 15 minutes plus 50 minutes. That makes a world of difference. You can see the number of visits that each community health worker has conducted. Next slide. And the pharmacist as well. Like I said, she hasn't met any of them in person, but she's making a difference. The average length of the baseline visit is about 40 minutes, again, answering questions and also intensifying treatment appropriately. She's using a treatment protocol to make sure patients are on the right medications as well. Next slide. And social determinants of health, that's the last thing I was asked to speak to. So if we want to control blood pressure, we really need to address social needs. And you can see for Linked BP and Linked Hearts, we had a lot of patients who had challenges with transportation, food insecurity, poor housing conditions. We will not take down hypertension if we ignore these social determinants. And so thank you so much for the opportunity, and I look forward to the questions.
Thank you, Dr. Commodore Mensa. Really appreciate it. At the end there, you're calling out the vital conditions for health and well-being because, as you said, we can't make progress without strengthening those. People face a lot of barriers in their lives that just simply make it impossible to keep up with health care in the way that they may want to, but they don't have the means to do so, or they have other alligators that are closer to the boat. So thank you very much for that. We have some great questions. We're going to try to get through as many as we can rapidly. The first one, Crystal Lynn, you're going to love this. Is there anything we can do? This is from Monica Ferguson, by the way. Is there anything that we can do to advocate for CMS to recognize pharmacists as providers?
Yes, Monica, thank you so much for asking. We have a bill in Congress right now that's called the Ensuring Community Access to Pharmacist Services Act. Yes, I had to cheat to remember that whole acronym. We call it ECAPS. It's HR 3164 and Senate Bill 2426. So this bill, you might look at it and not see hypertension in it front and center. It's a foot in the door kind of bill. We had a comprehensive try to get provider status for years and years, and the budget bill was just too big. So we contained it down into a test and treat kind of services bill. And this is our foot in the door attempt to get that problem fixed. Thank you, Monica.
Terry Ann Scott asks or says, we see many of the same challenges that exist with hypertension in the National Diabetes Prevention Program. And one of the biggest issues is helping healthcare systems and policymakers understand the urgency of prevention before chronic disease develops or worsens. Programs like the National Diabetes Prevention Program and blood pressure self-monitoring can address hypertension, obesity, prediabetes, and other chronic disease risk factors together through lifestyle change, coaching, nutrition, physical activity, and accountability. So, how do we better elevate prevention as a frontline strategy instead of waiting until disease progression? Dr. Spatz? And then Dr. Commodore Mensah?
This is a question after my own heart. I'm a preventive cardiologist, so I very much appreciate the question. There's several strategies are needed. Firstly, I think our societies are doing an amazing job. Our new blood pressure and lipid guidelines and diabetes guidelines are really pounding home how much more effective we can be at preventing disease if we start early and are more aggressive. I think there's a lot more attention to obesity as being the earliest sign of risk for cardiokidney metabolic syndrome, and that really means that we need to start early. I think that health systems are waking up to this idea that we need to get on the ball and that we need to refigure our health systems to achieve those goals. Right now, our acute care model is not working. And so I think trying different models and studying those models, different kinds of healthcare system strategies to prevent and address chronic diseases like hypertension is really important. So I'm excited about these new models, extended care teams that we're talking about today, the role of pharmacists and nurses and community health workers. I think that any recipes for success is going to need a multidisciplinary team that's addressing social determinants and really helping people engage in lifestyle behaviors, and then think about how do we use risk reductive medications appropriately when needed.
All right, thank you. Dr. Commodore Mensah, if you have anything to add, please do. If not, the next question is for you. So,
yes, I do actually. So
okay.
we know May is High Blood Pressure Awareness Month or May Measurement Month, but this is a special week. It's also Nurses Week. And so I would be remiss if I didn't mention that I'm also here in my capacity as the president of the Preventive Cardiovascular Nurses Association. So I'll just say that nurses represent our largest health workforce. So we need to do more to support the prevention of hypertension, but also prevention of cardiovascular disease. So PCNA, we are about to embark on a campaign to empower all of our members and chapters all over the country to go out into communities to increase awareness of high blood pressure and the dangers of not controlling blood pressure, but also educating our community members. As Dr. Spatz said, a lot of people may not recognize that obesity is a risk factor for high blood pressure. So I'll say that our professional societies have a critical role to play, but for all the nurses on this call, we have an important role to play, and there's strength in our numbers. Thank you.
Well, thanks, Yvonne, and congratulations to you on your election by your peers as president of PCNA. The next question is, I think, a really simple one. Dr. Spatz, you talked about self-measured blood pressure, home measurements being more accurate. Would it make a difference in SMBP utilization if Medicare covered home devices?
I think it would make a huge difference. Currently, Medicare covers for setting up a device. It covers for reviewing incoming blood pressures and communicating with patients around controlling blood pressure. It does not cover the device. And
Yeah, the
that is
logic is a little tough there.
the logic is a little tough. And so it's a challenge, and it leaves people either to, obviously pay for it on their own and then find the cheapest model. So then it creates a lot of noise. Is this a validated cuff? Can I rely on these measurements, especially when they're different from the office
Yeah.
measurements? And actually can increase cost if then the patient needs to buy another blood pressure cuff. It's also a major issue in our prevention of preeclampsia. When we want women who are delivering babies who either have a hypertensive disorder pregnancy or who are at risk, we want them to leave the hospital with the blood pressure cuff. And so we don't want them to have to go to the pharmacy or have any kind of lag period. The highest risk is immediately postpartum or postpartum, post-delivery. So we need to get coverage of those blood pressure cuffs. They need to be available in the moment that we need them so we can teach people proper technique and get them measuring their blood pressure.
Great points. Thank you. Dr. Commodore Mensah, you referred to those community-based programs, initiatives that Johns Hopkins has going. Do you think Medicare coverage for validated home blood pressure measurement devices would make a difference?
Absolutely. I would say yes. And that provision of the validated device should also come with additional support. As I mentioned earlier, for instance, in the state of Maryland, we just there was a bill that was passed to make sure that people diagnosed with hypertension and other chronic conditions have access to a validated blood pressure device. But where the bill fell short was paying for that additional support from community health workers and other clinicians to help improve awareness of blood pressure, but also self-management of blood pressure. So I think it's an important prerequisite, but I do think that we need to invest more in supporting community health workers who are already making a difference in terms of increasing the workforce to address hypertension. So I'll say yes, and more support, more clinical support.
Yes. Thank you. Dr. Weaver, the next question is for you. It comes from Norm Linsky. And our friend Norm says when he goes into his neighborhood pharmacy, which is part of a major chain, the team almost always asks about or encourages him to get vaccinated. And he says, that's great, that's progress. And he's wondering whether that approach could be applied, that same sense of urgency, to encouraging walk-in customers to cuff up.
Yes, I would love to see that happen. And I think the real barrier goes back to the aligning the incentives for payment for those services. So vaccines and also the scope of practice issue. So the vaccine authority for pharmacists dates back to the 80s, but we really saw a boom where it spread out to all 50 states after the H1N1 pandemic in 2009, I think. And then, of course, during COVID, has expanded greatly. So it's very consistent across state lines. It's easy for pharmacy chains and independents to implement that service at scale. And there's viable payment opportunities for the service so that we can invest in people to provide it. And it's really what we're lacking with other types of services that pharmacists and pharmacy technicians could be providing in the community setting. So it all goes back to the money, sadly.
Indeed, indeed. And I'm so glad you're making that point, Crystal, because I think we often in these discussions focus on the magnitude of the burden. We focus on the clinical and even public health tools that exist and say, okay, we leave with some expectation that people will put those tools to work, and it just doesn't happen. Well, why not? You just put your finger on it. It's because of the role of money in making decisions and prioritizing. So, if we're going to add urgency to hypertension detection, management, and prevention, we also need to align the incentives that direction, as you just said. So, I'm so glad that you just pointed that out. Um, Kayla Flores Tyndall asks, are any of our speakers or your team members affiliated with the American College of Lifestyle Medicine? She's wondering if any of you can speak to the power of lifestyle medicine and how it's incorporated into your successes, if at all. I see Yvonne nodding,
Yes,
so if you want to go first.
I'm not a member. I'm aware of this association, and in fact, they are part of the National Hypertension Control Roundtable. So I know we didn't touch on this, but in the Linked BP and Linked Hearts programs, it's emphasized that lifestyle modification is the foundation, really, of blood pressure controls, lifestyle plus medications, and in some cases, renal denervation as appropriate. So our community health workers were trained before they started the intervention, not just about, how to educate the patient on, changing their diet or physical activity, but also motivational interviewing. In some cases, people know what they should do, but I think we need to apply some of the skills in terms of how to counsel people, understand where they are in terms of stages of change. If someone is not ready, not willing, giving them time and until they're ready. And so this is something that is not only addressed by the community health worker, but our pharmacists as well. And it always gives me so much joy when Samantha talks about the importance of taking medications and lifestyle. And so we've also found that when our community health worker has a visit with the pharmacist, it's even more powerful because they're both singing the same song. And so we didn't talk about this earlier, but absolutely. Lifestyle modification is the cornerstone, and the recent guidelines have emphasized the importance of promoting lifestyle modification, but also considering that it's not enough to tell people to eat 5 servings of fruits and vegetables, but we need to make sure that people have food security, that they even have food to eat. And so we also need to balance the conversation accordingly. Thank you.
Well, your motivational interviewing, I think that's very important. You immediately brought to my mind with that comment that last year one of our speakers has survived 2 strokes. And he said right in the meeting, even though I'm a stroke survivor and that was awful, I still am not paying the attention I need to my blood pressure. I'm not controlling it, doing the things that I need to. So that motivation is so important. And I really appreciate in that context and beyond all the references that you've made, all of you, to community health workers who play such an important role. Dr. Spatz, anything to add about lifestyle medicine?
I love the question, and I love Dr. Commodore Mensa's comments. I completely agree that this is the cornerstone, and no matter what is happening with medications, we need to support our patients with lifestyle management. One of the things I love about home blood pressure monitoring is that patients gain insights for themselves. It's similar to diabetes care with CGMs. They can see the impact of a salty meal when they go out. If they have a dinner outside of their home, they may see their blood pressure higher in the morning. I like to give people really those SMART goals of exercise. We know that both cardio as well as resistance training can decrease blood pressure. And I show people how much blood pressure reduction we can expect when they are eating a certain, when they've reduced salt, eating more of a whole foods, plant-forward diet that's more of our Mediterranean style diet, websites to support culturally appropriate recipes that are in line with the Mediterranean diet are really important. Again, really discrete blood exercise goals that they can achieve over time. And then a real focus on stress management. So many of our patients are dealing with enormous stress or a history of trauma. Identifying that a history of trauma and supporting people with some biofeedback tools can also be very helpful with blood pressure reduction.
Very good. Thank you. Love the references you made, Dr. Spatz, to the quadruple aim. Something I surprisingly haven't heard for a while. So I think that's a valuable reminder. And again, as we're talking about aligning incentives so that health system decision makers can say, yes, we need to elevate the priority on hypertension control. The quadruple aim, it plays an important role there in helping them get to yes on that question.
Yeah, I think,
No, go ahead. Go ahead.
I think this is pretty common, is that health systems are operating not in abundance, but in scarcity. And so building that business case is really important for these health system strategies. And the numbers need to work out. And there's a lot of competition for health systems. So, patients happy, clinicians happy, retaining our healthcare workforce. We know that there's a tremendous healthcare worker shortage that is here now and is only going to be growing. So health systems need to have that mission to maintain their workforce, keep clinicians happy, endorse that team-based approach, which we know can improve our own work-life balance and meaningfulness and purpose. So I really try to hit home on all of those 4 points whenever I'm in a meeting, because I never know who's listening and who might be thinking, that's an issue that we're dealing with. And I think that I could see this as being one of the solutions to the problems that we're dealing with. So I really try to bring forward that quadruple aim in very concrete terms for our health system leaders.
All right. Thank you very much. A little programming note here. Our production team is working diligently in the background to solve some technical issues. So that's going to result in our deviating a little bit from the agenda that appears in your program book. But I think it should not cause any problems for us. And so at this point, I want to say a huge thanks to Yvonne Commodore-Mensah, to Crystalline Weaver, and Erica Spatz for really great comments. We appreciate you sharing your insights. This has been a valuable session.